Appreciate it. I also like to thank the organizers for inviting me to have this opportunity to address you today. So we've got about an hour or so that I'm going to cover a lot of ground, covering the basics of cannabis and other cannabinoids like CBD. We're going to cover, like I said, a lot of ground, and there'll be plenty of time at the end for questions and answers, and hopefully we'll hear a little bit about what your experience has been in Turkey with these compounds. So as you see there, my contact information is at the bottom, so feel free to think of me as a resource moving forward. Happy to be helpful in whatever way I can moving forward. So in terms of disclosures, as you heard, I've written a couple of books on this topic. So one in 2015 on the left from Hazelden, and then more recently on the right, a book just on medical cannabis. One of the things that we're going to be talking about today, really the therapeutic use of cannabis and cannabinoids. In addition to that, I'm a consultant to the National Football League, so I've the co-chair of the NFL Pain Management Committee, and have done that for the last 7 years or so, and also have consulted to the league on their cannabis and other substance policies. So what are we going to cover today? We're going to cover, like I said, a lot of ground. We're really going to focus on current epidemiology. So again, everyone is talking about cannabis. Lots of people are using it around the world. How has the use changed in light of differing policies? In the United States, for example, you're going to hear that we have about 38 states at this point that have medical cannabis policies, so it's quite prevalent. In about half of the country, about 24 states at this point, have legalized the recreational use of cannabis as well. So I'm going to show you slides that show how cannabis use has been changing in the context of changing cannabis policy. Second bullet here, we're going to talk about the basic risks and benefits of cannabis and other cannabinoids. And then finally, we're going to talk about the state of the evidence for the therapeutic use of cannabis and other cannabinoids. So again, with so many people interested in using these compounds medicinally, what is the level of evidence? In addition, that's going to give you some idea about how to talk to patients about this, right? Patients are very interested. Many of them will bring questions to their doctor or their clinician about using cannabis. Some are already using it, and so how you respond to their questions about this will be very important, because in some ways it may increase the likelihood, if cannabis is not an effective treatment for a given medical condition that somebody's using one of these compounds for, it may increase the likelihood that they will be willing to try something with better evidence. So if you talk about this in a sensible way, it increases your chances of being successful as a clinician. So a few references that I'm going to point out throughout the talk today. This was a paper that I published in the American Journal of Psychiatry at the tail end of 2021. It's a good starting point covering a lot of the issues that we're going to talk about today, and I'm also going to show you some slides from that talk. So again, everyone in the country and around the world are facing different policies about cannabis. Many states and countries are legalizing its use. So while that is happening, we have to be very clear about what the risks and benefits are. So we're going to start with the risks, then we're going to transition to the benefits. We're going to cover the idea of whether or not cannabis may be used to treat many psychiatric conditions, because there are many patients out there that are already doing this or think that cannabis or other cannabinoids like CBD may be helpful to treat their psychiatric conditions. So we want to know, what is the level of evidence? Everything we want to do is evidence-based, of course. I think it's very, very critical to be balanced on this topic. So in the United States, this is a very, very polarizing topic. People get very emotional. For example, when you think about substances that people may have an addiction to, let's look at the difference between alcohol and cannabis, right? If someone is using alcohol in a problematic way and you confront them about it, they will always recognize that it's problematic. No one is going to defend their use of alcohol as a medicinal agent, right? They're not going to say, well, that is actually good for me in these ways. Whereas if somebody's using cannabis multiple times a day and they've been referred to my clinic. As a result of that, they're going to oftentimes very adamantly defend their use. They're very emotional about it. And so that really colors the conversations that we have in the United States about cannabis. There's so much emotion wrapped up in this. And as a result, I think it's incredibly important to be as balanced as possible, both from a clinical perspective and a policy perspective. So clinically, again, if somebody comes in, it's very rare that they are coming in on their own, right? Somebody who's using cannabis in a problematic way, in my experience, is referred by a family member or an employer or someone else who cares about how they're doing. So the patient themselves are very ambivalent about it. So therefore, you have to understand when you sit down with them, they are having at least some perceived benefit to their use. So you have to, when you approach that clinically, you have to be balanced. You have to try to understand what they think the benefits are, but then also very carefully point out what the risks are. And so that's unusual in many senses, right? A lot of people will say, hey, look, doc, I know I'm drinking four or five drinks a day. I know that's a problem. Whereas if you talk to people about their cannabis use, they're not quite so sure. They're very ambivalent. So that ambivalence, which you see in treating any substance use disorder, oftentimes, is very, very pronounced with cannabis use disorder. So you have to be balanced. If you were just to harp on the negatives of cannabis use, and many of the things that we're going to talk about today, you're not going to get anywhere if you just hammer somebody with the problems associated with cannabis use. You have to try to understand what they're getting out of it or what they think they're getting out of it in a positive sense. Similarly, from a policy perspective, when we think about what has happened in the United States, again, there are very powerful and strongly held beliefs on either side. Many people believe that cannabis is an incredibly useful substance. They often believe that it has very few harms, and so they're strongly they're proponents of having increased access to cannabis and other cannabinoids as well. Similarly, on the other side, in my experience in the United States, there are many groups that are very staunchly opposed to cannabis use. Could be physicians, could be parents, but they're very strongly opposed to cannabis use. And what happens is both of these sides battle intensely as certain states vote on these policies. And unfortunately, what happens is either the pro side wins, those who are for it, or the anti side win, those who are against it. But after that decision is made, when a state has either voted for or against medical or recreational cannabis, the side that has not won will often retreat, and therefore they're not really a part of those policies. We lost here. We didn't want this to happen. Okay, this particular state's voting for it, so then that group turns their attention to another state where there may be a vote. And therefore, they're not having a meaningful role in making those policies. And when that happens, unfortunately, the policies are not as strong as they can be. So that's what we've seen in many, many states in the United States. It's not so much as to whether or not you believe you should have access to medical cannabis or recreational cannabis. I don't even know if that's the right question. In many ways, I think we need to think about, okay, if the people want something, how do we give them what they want while mitigating that risk? And that's what we have not done a great job. And it's not just the United States. I've collaborated with folks in other countries too, Canada, for example, and those policies are not as good as they could be as well. So we want to think about it. Wherever you are on these policies, by virtue of paying attention to a talk like this today, you're going to know more than most people. And so you're going to be in a position not only to work with your patients who may be interested in using cannabis or are using it, but you're also in a position to influence policy. So it's a great opportunity. In terms of the data, in terms of the epidemiology, this is an incredibly popular substance, and it has always been, but it has gotten more so over the years. So over around 200 million Americans, and actually those numbers are up above 200 now. So from 2018 data, 192 million Americans, and that's about 4% of the population from 15 to 64. And so what we've seen in the United States has been mirrored in other countries as well, Western Europe, Australia, for example. And so when you have so many people interested in this topic, you end up having people with very powerful agendas, and they can be people who are selling these products or people who are opposing these products, or they can be celebrities who have a strong belief about it. So as much as I'm grateful for the opportunity to address you today and for the opportunity to give talks like this around the country and around the world, I also have to recognize, as do you, that there are people who have much more powerful platforms. So if somebody who is a musician or someone who's selling millions of albums, if they come out and say something about cannabis today, they're going to reach a lot more people than I'm going to. And so therefore, it's not hopeless, but you have to understand that there are very powerful companies and people that are also going to be talking about this as we move forward. So in Turkey, one of the things I learned in prep for this talk today is that it is illegal for recreational use in Turkey, but there is some access available for medicinal use and scientific purposes. So in 2016, the legislation here approved the use of sublingual cannabinoid medications like Sativex. So Sativex is really the compound. It's not available in the United States, actually, but it's a compound that's made by GW Pharma, and that is pretty much the closest compound that you can get to the cannabis plant. So it has delta-9 tetrahydrocannabinol and cannabidiol more or less in a 1-to-1 ratio. So that is something that you do have access to in Turkey. And then similarly, people are allowed to grow cannabis for medical and scientific purposes in a number of provinces here. So also at the end, when we take questions, I'd be interested to hear what your experiences with cannabis has been. So while illegal here in Turkey, it seems like it has a fair amount of popularity, as is the case most places. So thinking about how to talk to people about cannabis, right? Understanding that the opportunities that you have to talk to patients may be fleeting, right? You may only get 1 or 2 opportunities. So how you do it when somebody comes in to see you for initial evaluation, let's say, or somebody raises this issue for the first time after you've been seeing them a while, how you talk about it is critical. So I think you need to talk about this cannabis in a sensible and evidence-based way. So things that are important. Number 1, most people who use cannabis, just like most people who use alcohol, as you can see here in the graph, looking at the prevalence of dependence, most people who use these substances do not develop an addiction. They do not develop a cannabis use disorder. So depending on where you look, the data indicate that around 10 to 30% of adult users who use cannabis develop a cannabis use disorder. So most do not. I think the numbers are probably closer to 10, so 9 or 10%. So I think that's important. When we think about younger users, the numbers are greater, so about 1 in 6 or so. So one of the things that I like to say when I'm addressing groups, particularly high school students or parents of those who are in elementary school or in college-age students, is that if I were to have a table of 6 young people using cannabis, only one of them will go on to develop a cannabis use disorder. Unfortunately, I can't tell you which one it's going to be. So that's part of the issue, right? You don't want to take those chances, right? If it's only 1 in 6, we want all of those 6 kids to have the best information possible, and their parents, so that they can make the best choices possible. That's really, as you'll see here, one of the themes for my work with cannabis is that I want to give people the best information so that they can make informed decisions. I'm not telling them what to do. I want to give you the information, and therefore you can make those decisions. Similarly, as we talk about only 1 in 10 or 1 in 6 of young people developing a cannabis use disorder, we have to understand that cannabis is less addictive than most of the other substances that people may use: alcohol, stimulants, opioids, etc. So in the United States, really the 3 largest groups of substances that are talked about are opioids. We have an opioid epidemic. Fentanyl is very popular in the United States, and when people are dying as a result of their use of fentanyl. Alcohol is the #1 substance used in the United States, and then cannabis. So really, in our clinic, I have an addiction psychiatry clinic at our hospital. Those are the 3 major groups: opioids, alcohol, and cannabis. So I think it's very important when you're talking to folks about using these substances that you recognize that it may not be as deadly as fentanyl, for example. So I like to think about a continuum, and so I think about different degrees of danger. So opioids are probably the most dangerous, right? People may use fentanyl and have an opioid overdose. Alcohol is very dangerous, maybe not in an acute way, but chronic alcohol use can lead to a host of problems. And then finally, cannabis. I think a problem that occurs sometimes in the United States when people like me are addressing young people is that if I were to go into a room like this full of high school age students and relay the message that cannabis is as dangerous as fentanyl, that's not realistic, right? I may not want them to use cannabis, but you have to be realistic about what the dangers are. So yes, you can absolutely risk your academic career, or you can lose relationships as a result of your cannabis use, but you're not going to have a fatal overdose. So I think it's important to talk about different degrees of danger. Opioids are probably more dangerous than alcohol probably more dangerous than cannabis. So being sensible about what the risks are, I think, helps you gain credibility with these groups as you talk to them. And then similarly here, as you can see, in the United States, over the last several years, as more and more states have been voting for cannabis policies, use in adults has been going up, and it continues to go up off the chart, right? This is on 2014 here. So the numbers keep going up. But I direct your attention to the middle line here. This is really the important line here, right? So use is going up among adults. Youth use is pretty flat, actually, but adult use is on the rise. But the purple line is where the problem resides. And so in this study from Wilson Compton at the National Institutes on Drug Abuse in the United States from 2016, they talked about perception of no risk of harm, right? So this is the issue. So as cannabis use is on the rise, perception of no harm is also on the rise. And what that means is that there is a lack of clarity about what the risks are, right? So in my view, if you have these policies in youth use may increase, or adult use definitely increases, I want adults and young people to have the best information. And what this suggests is that they're not clear about what the risks are. And as I like to say, if I were to go into a room like this with young people, let's say, and then we have we give them an exam about the risks of alcohol and the risks of opioids and then maybe the risks of cannabis, they're going to do very, very well understanding the risks of alcohol, understanding the risks of opioids. But they're not very clear about the risks of cannabis. And why is that? Part of that is because there's so many powerful groups that are trying to influence the messaging, right? Because there's often money at stake. If people are selling cannabis products or want to promote its use, then messages that really, are not clear about the risks, that's to their advantage. And so I think that's what we've seen here, is that unfortunately, we're not really doing a great job of educating anyone in the United States about what the risks are for cannabis. And then, importantly, it's a complicated topic, right? I mean, this is a complicated issue. So the cannabis plant itself has hundreds of chemicals. It's got cannabinoids, so those are chemicals that are specific to the cannabis plant. There are over 140 cannabinoids. There are other compounds too, terpenes, other phytocannabinoids, flavonoids. I mean, there are a lot of different compounds, but I think this is important because, as you can see, we're really only talking about a handful of cannabinoids usually, and there are over 140 of them. So delta-9 tetrahydrocannabinol, THC, that's the most popular one that we've talked about, can make you high on one hand, can also make you psychotic in an extreme, unfortunately. CBD, cannabidiol, is not intoxicating and probably has some positive properties. But importantly, we're talking about THC and CBD and some others, but we're just scratching the surface. There's 140 cannabinoids. So we will likely continue to learn a lot, but at this stage, it's important to emphasize what we do know. Why do we hear about THC and CBD together so many times? Well, that's because they're competing for precursors at a plant level. So CBD in some ways is functioning as a buffer of sorts to the potentially harmful effects of THC. And we'll hear more about that as we move on. So this is a slide that we took from the American Journal of Psychiatry paper that we published at the end of 2021. And I think this is important too because it underscores the complexity of not only CBD, but also the cannabis plant itself, right? So 140 cannabinoids, we're just looking at one of them right here. And as you can see, CBD has a host of effects at a variety of different receptors. So I think what we're doing is we're talking about how complicated this is and also how a lot of times people want to oversimplify this and say, well, it can do all these things, but they don't really get into what it means when you have so many effects. And I'll show you in a second what that means in terms of dosing. So CBD operating at multiple receptors. Here's just 5 that you can see here. Serotonin on the left. We've got a vanilloid receptor here, G-protein coupled receptor here. But each one of these receptors has different properties associated with it. And CBD is interacting with these receptors in a different way, right? Like it directly binds to these receptors. It functions as an allosteric modulator of THC at the cannabinoid receptors. It's in sort of an indirect agonist at the G-protein coupled receptor. So again, just kind of setting the stage for how complex this compound is and other cannabinoids as well. And this slide here I think is really important too, because as I said, CBD is functioning at multiple receptors, but the dose required to have CBD produce effects at these receptors differs quite a bit. So what does that mean? In the United States, a lot of people are using CBD, but they're using it at minuscule doses. And there is really very little thought given to the idea that, look, if you want CBD to operate in a certain way or produce a certain effect, then you need to think about what receptor it's going to occupy or affect, and then also what dose you need. So again, so many cannabinoid products like CBD, you can buy it in the United States 10 milligrams, 25 milligrams, but it's really not going to have very much effect at those doses very frequently. So I think that's one of the things that we've seen in the United States is that a lot of the CBD that's used is really producing a placebo effect because the dose is too low. And we're going to revisit this later. So just kind of think about this. If you are going to use CBD and have hope for it to do things, therapeutically, then the doses need to be pretty high, usually in the hundreds of milligrams. So we're going to circle back to CBD later because we're going to talk about how there are many side effects to consider, right? A lot of people think about CBD being harmless, while on the whole it's probably safer than THC, it's definitely not harmless. So let's talk about the risks, right? So I want to be balanced, and we're going to talk about the risks and the benefits of THC and CBD, and think about how that impacts the conversations that you may have with patients. So in terms of these effects, there are acute and chronic effects. I think you're more likely to be familiar with the effects of the chronic use of THC, but there are a lot of acute effects too. So let's cover them all. So acute effects, how can cannabis use affect you today? Number one, impaired judgment, right? So just like using other substances like alcohol, you may get into predicaments that you wouldn't otherwise get into as a result of using cannabis. And you may put yourself in unsafe situations, frankly, as a result of your cannabis use. The second bullet here, impaired coordination and motor skills. So cannabis affects your ability to drive. And so that's something that has always come up in the states that have been voting for these policies. What is this going to mean in terms of safety? And I think it's another example of where we need better education about what cannabis does, right? So people are not very clear about how cannabis affects your ability to drive, and it absolutely does in a similar but also a little bit different way than alcohol. So if you use alcohol, the errors that you make, you may not do the things that you need to do. So these are errors of omission, right? You may not check your mirrors if you're driving. You may not be careful about how you are monitoring your speed. Whereas if you're using cannabis, and again, it depends upon how experienced you are and what else you've done that day, but the errors that you make are errors of commission. A lot of times people will say, I think I drive better when I'm using cannabis. And what they're referring to, I mean, they don't, first of all. They're not driving better. But what they're referring to is that they are overcorrecting, right? They're going to be overcorrecting for being under the influence. So they, if the speed limit is in the United States 65 miles per hour on a highway, and they're driving 35 because they're being very, very cautious, that's still dangerous. So cannabis definitely can affect your ability to drive. Short-term memory loss and learning difficulties, as well as long-term. We're going to talk about that in a minute. And then finally, acute psychosis. So you can certainly trigger a long-term psychosis, but some of the psychosis that people experience when using cannabis is transient and acute, and so it may go away, but that can happen. Unfortunately, a lot of the psychosis that we do see is not transient, and once you trigger it, it's not going to go away. But we want to be clear about what the acute effects of THC are. The chronic effects, there are many more of them. These are probably things that you're more familiar with. But at the top, as you can see, I think it's important to note that the dose of cannabis, so what dose are you using, how often are you using it, it's critical, right? These effects are not going to occur with people using once a week or once a month. So again, in the debate about cannabis in the United States, sometimes there isn't complete transparency about this. People may want to steer people away from using cannabis, and they'll talk about all these things, but they won't talk about the idea that the dose is really important here. So if you're using cannabis at an early age in a regular way, early and regular use clearly affects your cognitive function. There have been some important studies. Madeline Meyer in the UK, 2012, Proceedings National Academy of Sciences, showed that those young people below 16 who are using regularly had up to an 8-point decline in IQ over time. Worsening anxiety, we're going to revisit this later because there's a lot of patients who think they're using cannabis to treat anxiety, so we're going to look at that data. But the data suggests that it worsens anxiety, worsens depression, increases the likelihood of having suicidal ideation, and then finally, Very strong data here, increased risk of psychosis. So if you have a family history of schizophrenia, schizoaffective disorder, bipolar disorder with psychotic features, you're more likely to express that if you're using cannabis, particularly at a young age. So the odds ratios are typically 1.5 to 5 or so. So it's very strong. Is it a causal relationship? That's something that's been debated. It's hard to say, but the data are very clear. That's why, again, when we're talking about educating people, providing informed consent before they use cannabis products, I think this is really important, especially if they have a family history of a psychotic disorder, that unfortunately, if you do, your risk is quite high here. So it may be a reason to avoid using cannabis. And again, talking about the dose-dependent nature of many of these risks, it's critical to know that the potency is in fact rising. So in the United States, 60s, 70s, 80s, average THC content 3 or 4%. Nowadays, average THC content is around 20%. So in the United States, we have medical dispensaries for cannabis. We also have other stores we can buy cannabis. So you can easily buy cannabis flowers in the 20s and 30%. So very, very potent. And we're going to talk about in a second other formulations of cannabis. So the potency is on the rise. And so as you need to understand that as you're using stronger cannabis, you're more likely to experience these problems that we talked about too, because they're dose dependent. So other forms of cannabis, here we've got synthetic cannabinoids. So this is when cannabinoids like THC are sprayed upon plant matter, and they're marketed in places usually where cannabis is not as easy to get. Who uses synthetic cannabinoids? People who are being drug tested in a regular way. So people who are in the military, people who are on probation in a penal system. I do a lot of work with professional athletes, and sometimes they're drug tested. So those are the people you need to think about. Also importantly, I mentioned earlier that CBD functions as a buffer of sorts to THC. So synthetic cannabinoids, there's no buffer. So the worst things that can happen with cannabinoids occur with synthetic cannabinoids. Here, we've got just vaping, different vape mechanisms. So again, you can vape THC. And then we're going to, a couple of slides to go more into detail on concentrates here, and then also edibles. So let's do that. So let's talk about edibles. To me, there's no greater example of poor education about cannabis and cannabis products than the fact that we have continued over the years. So we've had medical cannabis policies in the United States in various states since 1996, so decades, and yet we continue to have people show up in the ER after using edible products and overdosing. They're not fatal overdoses, but they're getting far more THC than they anticipated, and they end up in the ER. So this paper from 2023 showed over 1,000% increase in poisonings related to THC edibles from 2017 to 2021. And it gets to lack of understanding around dose and then also pharmacokinetics. So a typical dose in a brownie may have, like as you can see here, 100 milligrams of THC. So the average serving size, the recommended serving size, is 5 or 10 milligrams. So I don't know about you, but if I'm going to have a brownie, I'm eating the whole thing, right? I'm not going to have 1/10 of the brownie. So I think that's a place where people will take a bite, nothing happens because they don't understand the time course, the pharmacokinetics, right? If you inhale THC or you vape it, it's going to hit you pretty instantaneously. If you eat it, it's going to take 30 minutes or so. So what happens is people in states where they have people haven't had access to cannabis like this before, they say, okay, I want to try this. I don't want to smoke it. I want to use an edible. So they'll take a bite of a brownie. Nothing will happen. They'll say, what's going on? This isn't working. They'll take another bite. Nothing happens. So after 30 minutes or so, they may have taken 4 bites or so. So now somebody who is not experienced with THC is getting 40 milligrams of THC. And that's how you end up in the ER. So this should never happen. And we're not even talking about the packaging issues, right? Like there are sometimes when edibles are packaged like candy, and that should never happen as well. Concentrates, wax, shatter, butter, dabbing, those are some of the terms that people refer to when they talk about concentrates. This is when you distill THC plant matter down into very pure form, so 80 or 90% THC. So very, very potent. So therefore, as you can imagine, when we think about the dose-dependent nature of these problems, the worst effects of THC are more likely to occur at higher concentrations. You're more likely to have psychosis, hyperemesis. So these are syndromes where people who are using a lot of cannabis very frequently, they have these bouts of vomiting that are not relieved unless they stop using cannabis. Some other things that help them are hot showers, capsaicin, haloperidol, but these hyperemesis episodes are triggered by long-term use of very potent cannabis. So let's shift gears here. We're going to shift gears, talk about the evidence for therapeutic use. Then we're going to shift gears for really a final time, looking at can you use cannabis to treat psychiatric problems, and then we'll wrap it up and we'll take some questions. So thinking about the science, thinking about medical cannabis, right? I mentioned at the top that most states in the United States have these policies. So how are these policies employed? How do they decide what conditions somebody should use medical cannabis for? How does it actually look? You know, what happens? Does somebody write a prescription? You don't write a prescription for cannabis in the United States. You write a certification because cannabis is still illegal according to the federal government in the United States. So there's a lot of facts, and it ends up getting very complicated. But we've looked at this in a variety of ways, and so let's talk a little bit about what we've done. Before we look at the policies or where the evidence is, let's talk about what is available per the government in the United States. So there are 3 cannabinoids that are FDA approved. Dronabinol, which is oral THC. Nabilone is a cannabinoid 1 receptor agonist. So they're FDA approved for one of 2 things: nausea and vomiting associated with cancer chemotherapy, and then appetite stimulation in certain wasting conditions. More recently, cannabidiol was approved in 2018, and it's approved for 3 epilepsy conditions: Dravet syndrome, Lennox-Gastaut, and then also seizures associated with tuberous sclerosis. So we do have some cannabinoids that are available by prescription from a doctor, but the majority of cannabis that people use in the United States for medical purposes are not FDA approved, right? They're using it, like I said, federally illegal, but it is legal through the states that have it, so it's sort of a gray area. So here was a paper that we published in 2022, and what we wanted to look at was, number one, the policies, are they stipulating medical conditions with a lot of evidence or poor evidence? And then number 2, over time, like I mentioned, we've had these policies since 1996 in more and more states up until the current day. Are these policies becoming more tightly tied in with science over the years, which is what you would hope? So how do we do this? We graded, so there are about, there are over 40 conditions in the United States that states stipulate. There's a core group of probably 10 to 20 or so. We graded them all, and we used a system similar to the National Academies of Science, Engineering, and Medicine, who also put out a report in 2017 that we're going to talk about in a minute, very briefly. But what we found when we graded the evidence is that of the 42 qualifying conditions that were in place at the time when we did this study, 12% of them have good evidence, so most do not. So again, most of the conditions that these states are stipulating do not have good evidence. 50% of the qualifying conditions have no evidence or insufficient evidence. And then almost 10%, 9%, have evidence of harm, actually. So as you can see, these conditions are not really evidence-based. So this is an example of where policy gets out ahead of the science, right? People want this, people are selling these products, and therefore people are in a hurry to either sell the products or get the products, and so science takes a back seat. And that's really what's happening in the United States. And the number two thing from the study that we showed was that, unfortunately, as time has gone on, the policies have really not mirrored the science as well as we would like. We would want them to get better, right? That's part of the scientific method, right? If you perform an experiment and it doesn't work very well, or there's a problem with it, you like to look at it and figure out how to make it better. And we really haven't done that with cannabis policies in the United States, so they're not tied very well to science. Beyond the 3 FDA-approved cannabinoids that we talked about and the conditions that they're effective for, where is the best evidence? And so this was a paper that I published in JAMA, Journal of American Medical Association, in 2015, and I wrote at that time that outside of the FDA indications, the best evidence was for chronic pain, neuropathic pain, and then spasticity associated with multiple sclerosis. And I think the data could be better, but there's enough evidence such that if a patient comes in to see me for one of these things and they're interested in using either cannabis or cannabinoids, I think there's enough evidence to have the conversation. What else have you tried? Have you used multiple medications for chronic pain? Have you had injections? What's the story here? I think it's worth having that conversation. And so that's really where the best evidence is. I also point out, like I mentioned earlier, that CBD is FDA approved. And so that shows that if you really want to do rigorous science, that's one of the issues that's come up a lot of times in the United States, the quality of the science, the amount of the science. And if we really want to get the evidence, we can do it. The company that had CBD approved did it. So I think they should be held as a model of sorts as to how to do this the right way. I mentioned the NASEM report, National Academies of Science, Engineering, and Medicine. So they put out a report on health effects of cannabis and cannabinoids in 2017. That's a free resource available on the internet. It's worth checking out, although it's a little old at this point. We have a few projects in the works to try to update it. But what did the NASEM report show? They said, I quote, conclusive or substantial evidence that cannabis or cannabinoids are effective for chronic pain in adults, chemotherapy-induced nausea and vomiting, we knew that already, right, because there was an FDA approval, and then also patient-reported multiple sclerosis spasticity symptoms. And then another meta-analysis was in JAMA in 2015 by Penny Whiting from the UK, and she found that cannabis had moderate quality for chronic pain and spasticity. So to me, the take-home point is if you have my paper, the NASEM paper, and the Whiting paper, it's not that there are minor differences, it's more that there is some evidence. A lot of doctors in the United States are very much opposed to cannabis, and they say, well, there's no evidence. And that's not true. There is some evidence. There could be better evidence, and there could be more evidence, but there is evidence. And I think we would love to have better evidence, but there's enough to talk about this in a sensible way. All right, let's shift gears again. Can cannabinoids treat psychiatric problems, right? I'm an addiction psychiatrist. Many of you are psychiatrists here. We treat patients who have a lot of problems, and they're always looking for ways to treat these problems. And some of these are treatments that you prescribe to them, some are not. Like they'll try supplements or they'll try substances to try to manage their feelings and their psychiatric illnesses. So can cannabinoids treat these problems? Can cannabinoids treat anxiety? So as I mentioned earlier, this is one of the most common things that patients say. I use cannabis to manage my anxiety. And so we can appreciate that, right? If you're anxious and you smoke cannabis, your anxiety is going to go down. Unfortunately, your anxiety will rise up when the effects of cannabis wear off. So there's a rebound effect, and ultimately you're increasing your baseline level of anxiety. There's limited evidence of efficacy. There's been multiple RCTs that have looked at anxiety, but none of them have looked at this as a primary outcome measure. There appears to be decent evidence for anxiety, either in conjunction with other disorders, maybe social anxiety. Importantly, there are no studies in the United States that have looked at medical cannabis therapeutically to treat anxiety. So that's something that you hear. A lot of times patients will say, well, there hasn't been a study. Well, if there hasn't been a study done, then I guess one question is, does that mean you should use this or not? Should we wait for the evidence? I mean, that's an important question that gets asked a lot in the United States. A lot of Americans, frankly, will use this as a reason to try it, right? There has been, nothing shows that it doesn't work, so I'm willing to try this. Maybe that speaks to the level of desperation that they have. Post-traumatic stress disorder, another very common condition for which patients are using cannabis. Moderate level of evidence, although the number of studies is very low, 13 studies, 2 RCTs. Probably the most famous randomized controlled trial is by Jetley in 2015. It was a nabilone study. Importantly, though, and these aren't RCTs, but these are other important studies, crossover trial of smoked cannabis was negative by Marcel Bond Miller, and then another observational study of over 2,000 soldiers in the United States was also negative. I think that it's important to think about the weak level of evidence here. I would also say among cannabinoids for PTSD, CBD probably has the most promise, I would say, but using whole plant cannabis to treat anxiety and also treating PTSD, probably not a good idea. Can you use cannabis or cannabinoids to treat cannabis use disorder? So I think that's a good question. No medical cannabis trials. I've done a number of studies looking at the FDA-approved cannabinoids, but here's some other ones too. Dronabinol was studied in 2011 by Fran Levin's group at Columbia University. And they showed that dronabinol treatment led to better treatment retention and less withdrawal, but no separation in terms of abstinence. So overall, that has not really been developed as a good treatment. And then CBD more recently had a positive study by Tom Friedman's group in Britain. So 400 and 800 milligrams, safe and efficacious, better than placebo. So maybe there's some promise there, but at this point, we have no, in the United States, FDA-approved treatments for cannabis use disorder, and that becomes a problem over and over again. Opioid use disorder. So this is a critical topic. As I mentioned earlier, we have an opioid epidemic in the United States, meaning that we've had a lot of overdoses over the last several years, over 100,000 last year, and so thousands of Americans are dying from using fentanyl, really. I mean, fentanyl is far more potent than the other opioids that people have used in the past. So the question becomes, are there better treatments for opioid use disorder? So cannabidiol has been looked at. So Yasmin Hurd is a great researcher at Mount Sinai in New York City, and she did a human lab study looking at CBD, so 400, 800 milligrams again, reduced opioid craving and withdrawal. But there have been no interventional studies. So I think that Yasmin's study is very positive and very exciting, but I think ultimately we may see CBD as an adjunct treatment for opioid use disorder. It's not going to be a monotherapy. And so one of the things that we've seen in our state, in Massachusetts, is that, because again, we have medical cannabis policies, there are some doctors who are advocating for cannabis as an exit strategy from opioids, as a monotherapy. And I think that's a dangerous issue, right? We have really good treatments for opioid use disorder, buprenorphine, methadone, and naltrexone. So if you want to use CBD in addition to those, that's probably okay, but using it by itself when we have a deadly disorder, I think that can be an issue. And so, there have been some bad outcomes as a result of that. So a few more words about CBD. I mentioned earlier that I wanted to take a minute to tell you about the risks of CBD, because I think a lot of people promote CBD as a harmless medication, something less harmful than THC, which is probably true, but it is not harmless. So in the United States, we do have an FDA-approved version, but only one version. So because of the fact that only that version is approved for seizure disorders, a lot of people are using CBD for a lot of other conditions. And when they're doing that, they're using supplements, really. So they're not the FDA-approved version. So they're buying it over the internet or at other stores. And so while CBD is a very promising compound, most of the evidence to this point is preclinical. It's similarly, when you're not getting an FDA-approved product in the United States, the level of regulation, the purity and the potency are not as good. And so there have been multiple studies, as you can see here, that have shown time and time again that the products that you buy, the CBD products that you buy that are not regulated, are often mislabeled. And so the take-home point has been that about 30% of commercially available CBD products are accurately labeled, so most are not. So if you're using CBD, then, I think there's some good companies, but you have to understand that there's a decent chance that you may not be getting exactly what you're hoping for. Talk about the truth for CBD. What does the evidence show? Limited evidence so far that it's an effective treatment for insomnia. Number two, this is something that comes up a lot. People will buy very expensive CBD creams, and they don't understand that it's not absorbed into the bloodstream. So it's a topical anti-inflammatory, which is fine if that's what you're expecting. But I know that a lot of my patients feel that this is going to help a lot of things that would require systemic absorption, and that's not occurring. So it's another example where very good marketing is taking place. People are buying expensive products, but they're not going to get exactly what they're hoping for. And then finally, companies make very outrageous claims. They will say that CBD prevents concussions or things of that sort. And so if that's something that you're concerned about, then, here's this product that I can buy. So that's something that we've seen over and over again, that because of the lack of regulation for the majority of CBD products, you have issues related to purity, potency, and advertising. What are the potential side effects? So again, it depends on the dose, but I would maintain, as you've seen in today's talk, that you need high doses of CBD to be effective. If you're using high doses of CBD, then you need to check your liver function tests. So this Watkins study showed that in one of the Epidiolex trials, about half of the patients in one of the smaller studies had an increase in liver function tests very significantly. So I'm not saying that you can't use CBD, but you have to understand what the potential side effects may be. The second bullet here, dangers of CBD when you're using it instead of evidence-based treatments. I've had patients with treatment refractory depression say, who've had ECT say, I want to use CBD. That's not appropriate, right? It's not going to be a treatment for a treatment refractory depression. And then finally, it's very expensive. Because it's not regulated and you're going to need really high doses, it ends up being very, very expensive. So that's something that people need to understand when they're getting into this. Also, drug-drug interactions. So as we saw before, CBD is FDA approved for treating 3 seizure disorders. So this was a paper that we published in 2021. And we showed that CBD has significant drug-drug interactions. So just like any medication, you need to check a patient's other medications against CBD. So as you can imagine, for a compound that has efficacy for seizure disorders, other medications that might have efficacy for seizure disorders may have drug-drug interactions. So benzodiazepines, other anti-epileptics, and then other medications as well, like morphine, warfarin, so just to name a few. So there are drug-drug interactions that you need to contend with CBD. So winding it down, a few things to think about. What do you need to think about when you're talking with patients about this? I think number one, be sensible about it. Listen to patients. What do you think you're getting out of this? What is the perceived benefit? If you're willing to listen to what the perceived benefit is, you have a better chance of being able to say, well, I think this is probably a reason that we shouldn't use this, or this may be a better treatment. But if you're not going to listen to them, you're probably not going to get very far. Clearly, as our paper showed from American Journal of Psychiatry, for most psychiatric conditions, cannabinoids are not a good treatment. That may change over time, but at this point, there's not evidence for using cannabinoids for most psychiatric conditions. And then this point I think is important too. Clear communication and recommendations, right? Patients may decide to do things that you don't think they should do, but as long as you're being very clear with them about what you recommend and you document that, then they can make their decisions, and you can try to support them as much as you can. You're not endorsing it, but you're trying to help them with the best information you can, and you're going to document your recommendations. And I think that's a better conversation. That's a better way to have it than to have them feel like they can't talk about it with you, and therefore you don't know what they're doing. Right? I'd rather know what they're doing, even if it's something that I don't agree with. This slide's important too because it sort of looks towards the future and some of the problems that we're already seeing and that we'll probably see with other cannabinoids. So what happens when there are limited data, right? 140 cannabinoids. In the United States, we've continued to see new cannabinoids emerge and be marketed. CBG, CBDA, just to name a few. And we're learning more and more about them. I wish we could learn more faster, but we are learning some more about them. But then the question becomes, as I mentioned before, what are we going to do? If a new compound comes out and there's not a lot of data, does that mean that we should use it or not? I would hope that we would wait. I would hope that we would talk with our patients about other treatments that have more evidence versus having them try things that are really unproven. There are times when there aren't really great alternatives, I get it, but for the most part, we have a lot of people who are kind of prematurely launching into use of compounds that don't have a lot of data, and part of that is because of the marketing perhaps, but it's not a great situation. So this is something that we're seeing, and we need to be mindful about how we're going to talk about this with our patients. So overall, what we've seen in the United States, many examples of where people want something, they want to have access to cannabis and other cannabinoids, and they're not willing to wait for the science. And so our policymakers have gone ahead of the science in many places and written policies, as we talked about in our 2022 North American Clinics paper, that have medical conditions where there really isn't a lot of evidence. So it's not a great place to be. I am not proud of being in this position. I think that we should be doing a better job in the United States. I mean, we're not alone, but we could be doing better, and I think we should. So overall, this is where we are, right? People want these policies. People are going to be using cannabis. How do we give them what they want while mitigating risk? I think that's what we need. It's not about are you for it or against it. It's how do you give people what they want while mitigating risk. You can certainly tell them your feelings on it and where the evidence is there, but I don't want people retreating when these policies get put into place. We want you to have an active role in making better policy. We definitely need better research, for sure. But I also think that part of the reason we don't have that level of research is because a lot of the stakeholders, states, countries, companies that are making money as a result of cannabis products, they're not contributing to the science as much as they should. I think they should be forced to. You could say to a given state, like, hey, 5% of your profits should go towards research. And that really hasn't happened. So I think that if a country is considering having cannabis legalized, then they need to consider how to improve the science as they move forward. So with that, these are the permanent folks on my team back home. We have a lot of trainees, medical students, residents, et cetera, but these are the permanent folks who are watching the shop as I'm here. So I want to thank them, and then I'm happy to take some questions. Thank you.